Recording in progress.
हेलो। हेलो। हाँ मैम। मी एकदा हॅलो
हा
डॉक्टर
बोला
साहेब.
ना.
हाँ हाँ.
माझा आवाज
मी एकदा स्लाइड शेअर ट्राय करून घेऊ.
चालेल.
पार्वती मॅम जॉईन व्हायची आहे ना?
हो,
ओके.
दिसत नाही.
ठीक
नाही. हॅलो.
थोडा वेळ शांत मीटिंग. इथे मला टेबल पाहिजे. हिरवा टेबल कुठे गेला? आवाजच नाही येत मला.
हेलो मैडम. हेलो हेलो.
म्हणायचा आवाज
देशमुख मैडम.
नमस्ते सर.
नमस्ते नमस्ते मैडम. गुड आफ्टरनून. कल है आपके गांव में हम लोग.
गुड आफ्टरनून. आ गए क्या?
कल 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 आएंगे. आज
अच्छा
नहीं.
कल आएंगे. वेलकम सर.
बिल्कुल बिल्कुल.
खिडकी लावून द्या तू.
हॅलो मिताली मॅडम. हॅलो. हॅलो मॅडम, आवाज येतो माझा? मिताली मॅडम, हे टेक्निकल सपोर्ट कोण बघते आता? अर्चना मॅडम,
स्टार्ट
माझा आवाज
करते की
येतोय?
वेळ आहे?
मिताली मॅडम ना आपण? हॅलो.
हॅलो, मी अशी
टेक्निकल सपोर्ट कोण बघणार आहे? म्हणजे काय प्रॉब्लेम आला तर कोणाला कॉन्टॅक्ट करायचं? हॅलो,
हेलो तायडे मैडम ज्वाइन नहीं हुए क्या तायडे सर?
I am here. I have joined, sir.
By which name?
By which name? Acha, let me check. Sir, coming is my name, is it?
राज सर, मैथिली राज.
Acha, okay, I'll rename it. Sorry. It's fine now.
नारायण.
आवाज येतोय क्लिअर?
येतोय मॅडम, येतोय.
मॅडम माझा आवाज येतोय का? हॅलो,
येतोय मॅडम, येतोय आवाज.
जे जे लोक बोलणार आहेत मध्ये त्यांना को-होस्ट करणार का आपण?
हो त्यांना करतोय, पण मला त्यांचे नाव सांगा ना, कोण कोण बोलणार आहे.
नावं सांगते.
स्वाती काळे मॅडमला केलंय मी.
स्वाती काळे.
अजून नेक्स्ट अर्चना मॅडमला केलंय.
हा,
अजून
पाण्याची बॉटल देता.
जाधव सर.
जाधव सर, पडघन मॅडम, त्याच्यानंतर सुरसे सर.
एक मिनिट पडकर मॅडम. नेक्स्ट पार्वती
सुरवसे
राणे
सर
मॅडम.
आणि
सुरवसे
शीतल
सर काय
रोमन मॅडम.
नावाने जॉईन आहे?
गिरीश जी नमस्कार.
नमस्कार सर, नमस्कार.
सुरसे मॅडम घ्या.
सुरवसे सर काय नावाने जॉईन आहे?
नारायण सुरसे.
नाही आहे नारायण सुरवसे नावाने कोणी. सुरवसे सर काय नावाने जॉईन आहे?
खोसे मॅडम ना घेतलं का?
खोसे मॅडमला कोर्स केलं ना. तायडे सर नाही आहे का? हा झाले आहे. अश्विनी तायडे मॅडम. तायडे मॅडम. अजून कोणाला करायचं आहे? शीतल.
भावने सर.
शीतल रोमन शिंदे.
भावने सर आणि केसकर सर.
हाँ सर, नमस्ते.
नमस्ते भावने सर.
भावने सर नमस्कार सर.
तर शीतल मॅडम.
शीतल मॅडम काय नावाने जॉईन आहे?
मैडम ज्वाइन होता है, शीतल मैडम ज्वाइन करती है.
आणि पार्वती राणे मॅडम.
केलंय राणे मॅडमला.
डॉक्टर
मला
शीतल
नारायण सुरवसे नाव काय नावाने जॉईन आहे ते?
बहुतेक जॉईन नाही झाले आणखी.
बरं. तायडे मॅडम बरोबर केलंय त्यांना कोर्स. ते त्याच आहे ना त्या ज्या मी केलंय? अश्विनी तायडे मॅडमच आहे ना?
हो हो.
ओके ओके राईट. मी सगळ्यांना म्यूट करतोय. सगळ्या कोहोस्ट आपल्या तिथून आपण अनम्यूट करू शकाल. अदर दॅन कोहोस्ट कोणाला अनम्यूट करायचं असेल तर तसं दुसरे कोहोस्ट पण करू शकाल किंवा मला सांगून. All co-hosts can unmute from their system, either mobile or laptop. Other than co-host, if anyone wants to do unmute, either they can inform to any co-host or to me.
बाबांनी पण जॉईन केलं आहे.
हॅलो बावणे सर.
हॅलो, हा बोला.
सर सुरू करायचं आहे का की थांबायचं आहे?
जाधव सर
जॉईन होत आहेत. सुरवसे सर जॉईन होत आहेत. 1-2 मिनिट.
जाधव सर.
सुरुवाती सरांना जॉईन करा. पोस्ट केलं का सरांना? धागाजी
हा करतोय.
हा,
कोणाला
please.
करायचं सर?
सुरुवाती सर, नारायण सुरुवाती सर.
सर नाही जॉईन झालेले त्या नावाने. नारायण सुरवसे सर त्या नावाने जॉईन नाही आहे.
मी म्हणून join आहेत ना सर.
Please call to Dr. Survase and ask through which name he had joined.
Hello.
Hello, yes.
I have joined Dr. Narayan Survase.
Yes, sir. With the name of admin 3, na sir?
Yes, yes, admin 3.
Yes, yes. I have make you host. Okay, sir. Right.
Yes. Okay.
Thank you.
सुरू करूया दादा सर.
मॅडम. येस मॅडम.
Yes, sir. Yes, madam.
नमस्कार. मी डॉक्टर स्वाती काळे, व्हाईस प्रेसिडेंट वुमन्स फोरम निमा कल्याण, निमा महाराष्ट्र राज्य शाखा व वुमन्स फोरम निमा महाराष्ट्र राज्य शाखेतर्फे आपणा सर्वांचे स्वागत करते. त्याचबरोबर निमा सेंट्रल कमिटीचे प्रेसिडेंट डॉक्टर टेंभुर्णेकर सर, ट्रेजरर डॉक्टर कुलकर्णी सर, वुमन्स फोरम निमा सेंट्रल कमिटीच्या प्रेसिडेंट डॉक्टर कुलकर्णी मॅडम, व्हाईस प्रेसिडेंट डॉक्टर पडगन मॅडम, सेक्रेटरी डॉक्टर मासुतकर मॅडम, निमा महाराष्ट्र राज्य शाखेचे प्रेसिडेंट डॉक्टर जाधव सर, सेक्रेटरी डॉक्टर बाजारे सर, ट्रेजरर डॉक्टर वाणी सर, वुमन्स फोरम निमा महाराष्ट्र राज्य शाखेच्या प्रेसिडेंट डॉक्टर जगदाळे मॅडम, सेक्रेटरी डॉक्टर शेतपूरकर मॅडम, ट्रेजरर डॉक्टर राणे मॅडम आणि आपल्या वेबिनारचे कोऑर्डिनेटर डॉक्टर बावणे सर आणि डॉक्टर केसकर सर यांचे शब्द सुमनांनी स्वागत करतात. ज्ञान यज्ञ निमा महाराष्ट्र राज्य शाखेची वेबिनार सिरीज आपल्या सर्वांच्याच परिचयाची आहे. या ज्ञान यज्ञाचं हे 7वं पुष्प आहे. या देवी सर्वभूतेषु शक्तिरूपेण संस्थिता नमस्तस्यै 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 नमो नमः. या स्त्री शक्तीचा सन्मान करण्यासाठी 8 मार्च हा दिवस सर्वत्र जागतिक महिला दिन म्हणून साजरा केला जातो. दरवर्षी स्थानिक पातळीवर वुमन्स फोरम निमातर्फे सर्व शाखांद्वारे महिला दिन हा साजरा केला जातो. परंतु या वर्षी वुमन्स फोरम महाराष्ट्र राज्य निमा महाराष्ट्र राज्य शाखेने हा कार्यक्रम राज्य स्तरावर घेण्याचा मनोदय व्यक्त केला आणि निमा महाराष्ट्र राज्य शाखेने लगेच त्याला पाठिंबा देऊन हे 7वे पुष्प जागतिक महिला दिनाला समर्पित करण्याचे ठरविले. संघटनेतील स्त्री वैद्यांचा सहभाग वाढावा व त्यांचा नेतृत्वादी गुणांना वाव मिळावा यासाठी वुमन्स फोरम निमा हे खरोखर उत्तम व्यासपीठ आहे. घर आणि दवाखाना यांचा मेळ बसवत प्रॅक्टिस करणाऱ्या महिला डॉक्टर्सना वुमन्स फोरम मुळे आपल्या सहव्यावसायिकांसोबत सामाजिक, शैक्षणिक व व्यावसायिक स्तरांवर कार्य करण्यास व आपल्या हक्कासाठी लढण्यास योग्य पाठबळ दिले जाते. वुमन्स फोरम निमा महाराष्ट्र राज्य शाखेची आझादी का अमृत महोत्सव ही वेबिनार सिरीज जी सुरू आहे ती 15 ऑगस्ट 2021 पासून सुरू झाली. त्यातील हे 19वे लेक्चर आहे. अशा व्यावसायिकांच्या हक्कासाठी लढणाऱ्या नॅशनल इंटिग्रेटेड मेडिकल असोसिएशनचे जर आपण अजूनही सभासद नसाल तर आपल्या जवळच्या शाखेशी संपर्क साधून आपले सभासदत्व घ्या. निमाच्या कुटुंबामध्ये आपले स्वागत आहे. ज्ञान म्हणजे विषयाची जाण, विषय समजणे. जेव्हा विषय समजतो तेव्हाच त्याला आपण म्हणतो की त्या विषयाचे ज्ञान मिळाले. जेव्हा समज हा शब्द येतो तर त्यासोबतच गैरसमज हा सुद्धा शब्द त्या पाठोपाठच येतो. तर आज आपण असेच गैरसमज दूर करायला, अर्थात ते इन्फेक्शन बद्दलचे गैरसमज दूर करण्यासाठी म्हणून इथे जमलेलो आहोत. आपला आजचा लेक्चरचा टॉपिक आहे डिमिस्टिफाइंग मिथ्स अबाउट कॉमन इन्फेक्शन आणि आपल्या आजच्या वक्त्या आहेत डॉक्टर अश्विनी चौधरी तायडे मॅडम. ज्ञान यज्ञाची सुरुवात आपण आपले आराध्य दैवत भगवान धन्वंतरी यांच्या स्तवनाने करणार आहोत. वुमन्स फोरम निमा महाराष्ट्र राज्य शाखेने ऑक्टोबर 2021 मध्ये राज्यस्तरीय गायन स्पर्धेचे आयोजन केलेले होते. या गायन स्पर्धेच्या प्रथम पारितोषिक विजेत्या डॉक्टर अर्चना देशमुख मॅडम यांना धन्वंतरी स्तवनासाठी मी पाचारित करते. हॅलो, मॅडमचा आवाज ऐकू येत नाही. हॅलो, बाकी कोणाला येतोय आवाज ऐकू?
ते म्यूट आहेत, अनम्यूट करावं लागेल.
मॅडम म्यूट आहे. मैं कॉल करती हूँ मैम.
डॉक्टर अर्चना देशमुख मॅडम, तुम्ही होस्ट आहात, तुम्ही अनम्यूट करू शकता तुमचं.
देशमुख मॅडम अनम्यूट करा तुम्हाला.
हॅलो हॅलो, आता आवाज येतोय का?
हो येतोय.
हॅलो हॅलो,
इको आहे मॅडम आवाजात तुमचा.
येतोय? सुरू
दोन
करते.
डिव्हाइस जरी असतील मॅडम, एक डिव्हाइस बाजूला ठेवा, त्याच्यामुळे इको येतोय.
अच्छा, आता येतो आहे?
हो हो हो
हो, छान आहे करून.
सुरू करते मॅडम.
येस मॅम.
नमामि धन्वन्तरि मादिदेवं सुरासुरैर्वन्दित पादपद्मम् लोके जरारुक् भयमृत्युनाशं दातारमीशं विविधौषधीनाम् अमृतार्थी देवदैत्ये केले उदधी मंथना त्यातुनी जोवरी आला विश्वाच्या स्वास्थ्य रक्षणा विष्णूंचा अंश प्रत्यक्ष असा धन्वंतरी प्रभू करो कल्याण विश्वाचे सुधा कलशधारी हा विख्यात कीर्ती भगवन स्मर्यवेव नामे धन्वंतरी करिदुरी विपदा जगाची संपादिला निज बळेची हविर्विभाग आयुष्य वेद जनका अमुसे प्रणाम ओम धन्वंतरये नमः ओम धन्वंतरये नमः.
धन्यवाद मॅडम.
थँक्यू मॅडम.
आपले निमा महाराष्ट्र शाखेचे अध्यक्ष सर्व परिचित डॉक्टर जाधव सर यांना मी त्यांच्या अध्यक्षीय भाषणासाठी निमंत्रित करते. जाधव सर.
Good afternoon, dear friends. Am I audible, madam?
हो सर.
Yes. Good afternoon, dear friends. Respected Dr. Vinayakji Temburnikar sir, President NIMA Central Council. Respected Dr. Ashutoshji Kulkarni sir, Treasurer NIMA Central Council, and our guide, respected Dr. Sadhana Kulkarni madam, President Women's Forum Central Council. Respected Dr. Vaishali Padgan madam, Vice President Women's Forum Central Council, and today's chief guest for our 7th webinar in this Jnana Yajna online lecture series for all our ICM graduate friends on the occasion of International Women's Day. Respected Dr. Mrunmayee Masudkar, Madam Secretary, Women's Forum, Central Council. My colleagues, Dr. Anilji Badare sir, General Secretary, and Dr. Bhushanji Vani sir, Treasurer, NIMA Maharashtra State Branch. My colleagues in the Women's Forum, Maharashtra State Branch, President, Dr. Swapna Jagdale Madam, Secretary, Dr. Rajeshwari Shivpurkar Madam, and Treasurer, Dr. Parvati Rane Madam, Organizer, Dr. Mate Madam. Today's speaker, Dr. Ashwini Ji Chaudhary Saide Madam from Nagpur, Chairperson, Dr. Narayanji Survasi Sir from NRS Hospital, Pune, Co-Chairperson, Dr. Sheetal Roman Shinde Madam from D.R. Patil Ayurved College, Pimpri, Pune, and you all ever ready to grasp knowledge update across the Maharashtra state and out of Maharashtra state. Greetings to you all from National Integrated Medical Association, NIMA, Maharashtra State Branch, Executive Committee, and all members. Today, we are going to have 7th lecture in our state-wide webinar series, Jnana Yajna. Thank you for your overwhelming response to all previous 6 webinars on behalf of Jnana Yajna webinar team and all members of NIMA Maharashtra State. And I hope and I trust that your support and your response will be continued in the future also. My sincere thanks to Women's Forum Maharashtra State Branch, President, Secretary, especially Treasurer and Organizer, who took efforts to organize today's webinar. My sincere thanks to the speaker, Ashwini Chaudhary Saide Madam, from Kingsway Hospital, Nagpur, consultant, infectious diseases and adult vaccination. Hello?
Hello. Hi, sir.
There is some disturbance, I think. In today's scenario, we are facing many new forms of infectious diseases, especially in COVID-19 first wave, second wave. We faced many patients with chest infection and other associated infection with or without comorbid conditions, facing serious and fatal infections, which resulted into a large number of deaths. That's why it is also important and necessary for us to know more about it, and especially demystifying myths about common infection. Like you, I trust that Ashwini Madam will give us the updates and will elaborate the topic with sound knowledge. In the due course, NIMA Maharashtra webinar team will come out with more and more interesting topics for updating your knowledge in the coming months. My sincere thanks to Dr. Vishnu Bhavane sir and Dr. Padmakar Eskar sir for taking the burden of every webinar on their able shoulder. Of course, the entire webinar team, Dr. Daga sir, Dr. Mani Doshi sir, Dr. Lad Madam, Dr. Isokar sir, and everybody from the webinar team making tireless efforts for making you the knowledge, and that's why the success story of this Jnana Yajna webinar series for entire state and for the nation. National Integrated Medical Association, the largest medical association in our country for guarding the rights of our integrated and Ayurvedic practicing doctors, is soon entering in Platinum Jubilee year from 30th April 2022, Amrut Mahotsav. When we look back to this long journey, NIMA has tirelessly fought for establishing and guarding the rights of all our ICM doctors in the country, irrespective of member of NIMA. Wherever a cry or injustice to our ICM doctor, BMS, BUMS doctor is being noticed. NIMA within no time came forward, intervened, and provided every help to give justice to him or her. NIMA will continue doing so for all our ICM doctors in future also. Thus, I appeal to all who are yet to become NIMA member, please be a part of a large NIMA family. You may contact me or any one of our office bearer or NIMA family member anywhere in the Maharashtra state and be the proud member of NIMA family. Today, we have occasion of International Women's Day. Our Women's Forum Wing of NIMA Maharashtra State Branch took initiative to organize today's Jnana Yajna webinar, that too by a lady doctor, Dr. Friday Madam. I, being the head of the NIMA Maharashtra State family, am proud to state that the lady doctors in NIMA Maharashtra State branch are doing a great and spectacular work. There are total 98 branches in our country of Women's Forum. Out of it, 48 are from Maharashtra State, and I'm almost all branches in Maharashtra State are active and organizing many programs for lady doctors. NIMA Women's Forum Maharashtra State, under guidance of Dr. Kulkarni Madam, Padyan Madam, and Masotkar Madam, are progressing rapidly, and then they deserve a round of applause. Also, Women's Forum NIMA Maharashtra State branch, under able leadership of Dr. Jagdani Madam, Dr. Shirpurkar Madam, Dr. Rani Madam, and Dr. Mate Madam, are making great efforts to organize the Women's Forum team in the Maharashtra State and enlightening the spirit of unity and togetherness in lady doctors in the state. I hope they will continue the efforts in the future also. Friends, I hope that many of you have attended the meditation and pranayam sessions organized with Art of Living Doctors team and have gained psychological support. Let's meet again in the next webinar. Thank you all for your increasing support and best wishes. Thank you. Jai Hind, Jai Maharashtra, Jai NIMA.
सर सरांनी मार्गदर्शन केल्याप्रमाणे खरोखरच आपलं हे जे मोठं कुटुंब आहे त्या कुटुंबातील सगळ्यांची कामगिरी शब्दात आपल्याला व्यक्त करता येत नाही, पण त्यांच्या कामगिरीमुळे आपल्याला होणारे जे फायदे आहेत ते मात्र आपल्याला दिसून येतात. धन्यवाद सर्वांचंच. यानंतर निमा सेंट्रल कमिटीच्या व्हाईस प्रेसिडेंट आणि आजच्या कार्यक्रमाच्या प्रमुख पाहुण्या डॉक्टर पडगन मॅडम यांना मी त्यांचे मनोगत व्यक्त करण्यासाठी विनंती करते. पडगन.
हॅलो हॅलो, ऐकू येतंय ना?
Yes, ma'am.
सर्वप्रथम भगवान धन्वंतरींना माझा मानाचा मुजरा. हॅलो मॅम, डिअर कलिग्स, my sincere regards to NIMA CC President Dr. Tembudekar sir, Treasurer Dr. Ashutoshji Kulkarni sir, Padgan sir, our Women's Forum CC President Dr. Sadhna Kulkarni Madam, Secretary Dr. Masotkar Madam, and Maharashtra State President Dr. Suhashji Jadhav, Women's Forum President Dr. Jagdale Madam, and all other dignitaries of NIMA. My sincere regards to all of them and thanks for inviting me for this Women's Forum special webinar. Wish you a very happy Women's Day, rather Women's Week to all my Women's Forum members. This is 7th webinar of Jnana Yajna arranged by NIMA and Women's Forum. This is specially designed for you all to satisfy your desire toward knowledge and update your practicing skills. In previous 6 webinars, we have already discussed so many topics. Today, our honorable speaker, Dr. Ashwini Chaudhary Tade Madam, will give her valuable guidance about infectious diseases. NIMA organization is formed before 74 years, and now we are celebrating 75th year Amrut Mahotsav, Platinum Jubilee of this greatest organization of medical fraternity. NIMA serves to solve problems of our graduates, practitioners. It serves for our betterment. We have to celebrate this year with programs designed by our dignitaries. We have total 8,000 NIMA branches all over India. New 13 women's forum branches formed all over India. In Maharashtra, there are 49 women's forum branches. Now there are new wings also formed in NIMA, like Gynec obstetric wing, surgeons wing, teachers wing, students wing. Students forum also have 11 branches formed, which helps in our graduates in every way in their every problem. Our respected Dr. Sadhna Kulkarni madam dreamed about a separate platform for lady doctors in NIMA, and the dream come true in a wonderful way. Dr. Masotkar ma'am, Secretary NIMA Women's CC, is doing dazzling performance. She inspires in creating new branches of Women's Forum all over India. It is a very creditable job. Our Maharashtra Women's Forum President Dr. Jagdale Madam is doing outstanding performance. In her tenure, 49 Women's Forum branches are formed in Maharashtra. Heartiest congratulations to her whole team for working hard to implant creative ideas, seminars, sports tournaments, singing competitions, and so many other activities, which bound all our branches and members together, and they all enjoy in every way. Now, Women's Forum is the most active forum of NIMA, and I am very proud of being a part of that. Our every women's forum is precious for us and who is doing extraordinary work. Salute to the women here. NIMA has done a tremendous job in COVID pandemic also. It has served to the patient in this horrifying condition also. Women's Day is a special day for us to celebrate womanhood. As a doctor, we should serve to the needy persons, peoples in society, but we should also enjoy with our friends. It is important to get relaxed from day-to-day practice and stress, and this is perfectly done by Women's Forum and their various activities. As a doctor, we are serving to the society, we are practicing, we are doing, we are updating our knowledge by attending such seminars. So we are doing every way, and our forum, NIMA and Women's Forum is helping us in updating our knowledge. Thanks for that. So not taking too much of time, enjoy and concentrate with the next session and Gyan Yagya. Thanks for being with us. Jai NIMA.
आजच्या आपल्या लेक्चरला चेअरपर्सन म्हणून आपल्याला डॉक्टर नारायण सुरवसे लाभलेले आहेत. ते अतिशय उत्साही, कार्यकुशल व चतुरस्र असं व्यक्तिमत्व आहे. त्यांचे MBBS व MD मेडिसिन म्हणजेच UG आणि PG हे दोन्ही गव्हर्नमेंट मेडिकल कॉलेज नागपूरहून झालेले आहेत. अकॅडमिकल, क्लिनिकल आणि रिसर्च या तिन्ही स्तरांवर सरांचं भरीव योगदान आहे. रोल ऑफ सायकोलॉजिकल स्ट्रेस इन अक्यूट मायोकार्डियल इन्फाक्शन या विषयावर सरांचे आर्टिकल प्रकाशित झालेले आहेत. सरांना सामाजिक कार्यासाठी राजीव गांधी पुरस्काराने 2019 मध्ये सन्मानित करण्यात आलेलं आहे. कॉंग्रॅच्युलेशन सर अँड वेलकम टू दिस सेमिनार. त्याचबरोबर आज आपल्याला को चेअरपर्सन म्हणून डॉक्टर शीतल रोमन शिंदे लाभलेले आहेत. मॅडमनी BAMS MD शारीरिक क्रियामध्ये केलेले आहेत आणि त्या PhD स्कॉलर आहेत. सध्या मॅडम DY पाटील कॉलेज पुणे येथे शारीरिक क्रिया विभागात प्रोफेसर म्हणून कार्यरत आहेत. मॅडमला 14 वर्षे UG आणि 11 वर्षे PG टीचिंगचा अनुभव आहे. राष्ट्रीय व आंतरराष्ट्रीय स्तरावर मॅडमचे अनेक आर्टिकल्स प्रसिद्ध झालेले आहेत. शारीरिक क्रिया प्रात्यक्षिक हे त्यांचे पुस्तक 2019 मध्ये प्रकाशित झालेलं आहे. तसंच मॅडमला 2021 मध्ये ATA चा अवॉर्ड मिळालेला आहे. बेस्ट नॅशनल टीचर अवॉर्ड क्रियाशाली हा प्राप्त झालेला आहे. कॉंग्रॅच्युलेशन्स मॅम अँड वेलकम. आपलं जे लेक्चर होणार आहे त्या लेक्चर मध्ये जर कोणाला प्रश्न वगैरे काही विचारायचे असतील तर ते त्यांनी चॅटबॉक्स मध्ये टाकायचे आहे. चॅटबॉक्स मध्ये विचारलेले प्रश्न नंतर क्वेश्चन आन्सर सेशन मध्ये घेतले जातात. आपल्या को चेअरपर्सन डॉक्टर शीतल रोमन शिंदे यांना मी आपल्या आजच्या वक्त्या डॉक्टर अश्विनी चौधरी तायडे मॅडम यांचा परिचय करून देण्याची विनंती करते. Dr. Sheetal Roman Shinde. मॅडम अनम्यूट होत नाही का?
अनम्यूट करा मॅडम.
थँक्यू काळे मॅडम. माझा आवाज येतोय का?
येतोय, बोला मॅडम.
येतं मॅडम.
Good afternoon, everybody. Respected President NIMA MSB, Dr. Suhas Jadhav sir, NIMA Women's Forum Vice President Dr. Vaishali Padghan madam, our Chairperson Dr. Narayan Survase sir, Speaker Dr. Ashwini Chaudhary, and all the participants of Gnan Yajna webinar. I am glad to introduce today's speaker, Dr. Ashwini Chaudhary Taide madam. She has done her MBBS from GMC Nagpur and also her MD from IGGMC Nagpur. She is DNB MD General Medicine. She has done her fellowship in infectious diseases from DNB Board Apollo Hospital. She is certified in tropical medicine ASTMH Atlanta, USA. She has completed her observership in transplant infectious diseases from Wayne State University, Detroit, USA. She has done her international tropical medicine short course from CMC Vellore. Currently, Madam is working as a consultant infectious diseases at Kingsway Hospital, Ramdaspet, Nagpur, where she handles the adult vaccination clinic and infectious diseases clinic. She is an executive member of Governing Council Clinical Infectious Diseases Society, also member for Medical Assistance to Travelers. She is a member of Infectious Diseases Society of America. She also served as a member of Mucormycosis District Task Force, Nagpur 2021. Ashwini Madam has worked as a faculty for SIDSCON, APICON, National and State CME and conferences. She also has 2 chapter contributions to her credit. She was the organizing secretary at SIDSCON 2017. Ma'am has received Young Achiever Award at Vidarbha API Vapicon 2020. Her areas of interest are adult immunization, HIV, MDR, XDR, tuberculosis, and zoonosis. Before handing over to Ashwini ma'am, I would like to say that she is going to guide us today on demystifying the myths about common infections. ज्या काय आपल्या मनामध्ये इन्फेक्शियस डिझीज बद्दलचे समज किंवा गैरसमज रादर आहेत त्याच्याबद्दल मॅडम आज आपल्याला गाईड करणार आहेत. नाव आय हँड ओव्हर टू डॉक्टर अश्विनी मॅडम. मॅडम प्लीज.
Thank you, Sheetal ma'am, for such an elaborate introduction. First of all, I'd like to thank Parvati madam and Jadhav sir and whole NIMA association for giving me this opportunity of being here on this wonderful platform with all your esteemed people. Just while going through the NIMA website, I came to know that it's a 75-year-old organization. So it's really a old organization with strong pillar, with faith in Sarve Santu Niramaya, which is very strong concept actually. And this organization has contributed a significant chunk to healthcare system in India, and I guess it's a major pillar of healthcare system in India. So hats off all the office bearers, the torch bearer for the organizations who have maintained. And in the initial part of program, I have like it was narrated, there were so many branches and subcommittees of the organization, which is really commendable to have all these subcommittees, and particularly for the women's subcommittee, there are so many subcommittees in that is really commendable. So again, I'd like to thank NIMA for giving me this opportunity. So we are meeting on the occasion of Women's Week or World Women's Week. So I'll just start with the proverb from Mother Teresa, which says, "I alone cannot change the world, but I can cast a stone across the waters to create many ripples." So this is really a powerful, inspiring word. And we should be thankful to all similar females who have set the stage for us and who have set the example for all of us to do something significant in our field and come forward and contribute to society. So there is always a will, and there is always a way when there is a will. Be it a men's world or women's world, we know what is important is desire to change or desire to bring the change. And that is the key behind success for everyone. So I really like the NIMA slogan, which is "We can and we will." Yes, we can make the change which is required in the healthcare system, and we will definitely make the change. And for to bring all this change, I guess we have to keep updating our knowledge, because there is a lot happening in the field. And with COVID, yes, there are the infectious disease especially has really come to got the importance or got the recognition with COVID coming up. We know we live in a country wherein it's mainly tropical country, and there are a lot of infections we see. Majority of our practice is basically related to infections. So definitely infectious disease is a part of significant part of our practice, and in our day-to-day practice we keep seeing so many patients related to infections. So that is why I guess today's topic holds importance, particularly when we are dealing up with infections. And yesterday I read China has closed the border because they have found new virus. So we really don't know whether COVID is just end of the pandemic era, or it's just the beginning of pandemic era or bioterrorism era, and we have many more viruses or many more bugs to come and create problem for us. So there are myths, and we know myths are there with all infections, or myths are associated with everything. With COVID, yes, we have faced a lot of myths, be it related to the COVID, antibiotic related to COVID, or COVID treatment, cocktail, or be it related to COVID vaccine or the sprayed infection control. There are multiple issues which we had discussed related to COVID. Coming back to our major thing, as I said, we live in a tropical country. So India is a tropical country, and majority of our infections or majority of our OPD consults, what we see, even OPD or inpatient, what we see revolves around the infection. This infection might be just a simple staph, boil, cellulitis, or it might be TB, which is very common in India. Or sometimes we get surprises like milioidosis, Kala Azar, though it's not so common in this part of the world. But yes, we do get all these patients. And particularly with COVID, the challenges are even more, because post-COVID, what we have seen is complete new spectrum of infections or mixed infections. There are polymicrobial infections, there are a lot of lung infections, and connective tissue has flared up. TB is started coming up. There are multiple patients who are coming up with TB. They were undiagnosed while COVID and went on with long-term fever. The other thing in COVID is migration. So we have to keep in mind, not necessarily the person should be from this area. So whenever person comes with the infection or any syndrome or any diagnosis, we have to keep in mind the past history also, because that person might have migrated from some other area. Like I might get a person who has stayed in Bihar and come to me with fever. So then Kala Azar should come to my mind. So getting this history is really important, and these challenges are, we are going to face all these challenges, and I guess we will learn with time to face all these challenges. The problem what we face in practice is availability of diagnostic modalities. So not everywhere every test is available, and sometimes we have to make diagnosis with whatever is available with us, be it just a clinical diagnosis, diagnosis based on our examination, or the minimal basic test what we have available. Sometimes we have based of the labs available with us, and sometimes we don't have it. Just a simple example, like I might have test which a very person might not have, but then if someone who is in metro, or someone who is, if we compare it to someone who is abroad, he will have better access to the diagnostic modality, which will make making a diagnosis really easy. But yes, even if we have diagnostic modalities available with us, we should know how to interpret it, how to utilize it. So sending an appropriate test at appropriate time is really important in getting a diagnosis. Otherwise, there is plethora of tests available, and if we keep sending all these tests without knowing what to do, we might land up in this kind of situation. And that's what happened in clinical practice. And that is when ID gets roped in actually. So we get consults wherein, yes, steroids are given, PET CT is done, there is no diagnosis, so now come and solve it. So it's kind of a detective job. And I guess that's what was seen by this journalist lady. And that's why she labeled me as a detective doctor. Yes, being an infectious disease, it's kind of a detective job, because whenever we have a patient with infection, or rather all of us, we have a patient with infection, what we have to do is a thorough history, which might include your very personal history also, like your exposure history, your habits, your profession, because these might give you clue related to your infection, what exactly you're going through. So knowing your patient in detail, getting the history in detail is really important. This will be a case-based discussion. So I'll have few cases, what we see in our day-to-day practice, and then we will have a discussion subsequently. Do we have a voting option or giving answer available? They can write the answer in chat box if people want to participate. So a young female comes to me with a fever of 2 days. What will I do? Will I ask for any test? I'll just do a CBC, WBC count, malarial parasite, because we know malaria is really common, or I'll do a urine analysis because majority of the females, they do get urine infections or cystitis, that is commonest symptom. Or I do WBC count, MP, and blood cultures, because I feel blood cultures are really crucial, and they have changed the game in this today's scenario. So what should be the answer? If anyone wants to answer, please, I'll be opening my chat box also. Okay. So basically, what is important is, as I said, reviewing your history, and majority of the patient, what we see in our practice, they reach to us maximum after a day of fever. So maximum come to us on day 2 of fever. And then subsequently, yes, they do come to us, and we do have, particularly when I see my patients, majority of my patients are long-term fever, burnt out fevers and all. But majority of patients come on day 2. This is an article which was published in Indian Journal of Science, where they have seen that total death of patients without need for investigation was almost 75%. So the crux is we should not hurry up while investigating the patient, and that too without antimicrobial, again 50 or 60%. So the important part is not everything is infection and not every fever needs antibiotic. So we should be patient, and it's really tough to be patient because your patient is impatient and he needs diagnosis, he needs result, and he wants to get back to work in a day's time. They feel, yes, we are going to doctor, so in 1 day fever should come down. But that doesn't happen. We have to do a thorough systematic approach, and then only the outcome will be really good, and we'll be able to save unnecessary investigation, unnecessary antibiotics for the patient, because we are living in an era of antimicrobial resistance wherein hardly any antibiotics are working. So the algorithm basically says day 1 or day 2, if we have someone, defer the investigation and antimicrobial also. This doesn't hold true only for few patients, wherein like I have a patient with transplant and fever. Yes, I cannot sit tight and I cannot observe. In that case, I'll intervene, I'll do the investigation, or I'll do a thorough examination, I'll take thorough history, and I'll decide what are the possibilities based on the patient clinical status and risk factor. In normal case, in normal host, day 3, day 4, yes, we should do the basic blood test like complete blood count, which will give us idea whether there is neutrophilia, whether there is lymphocytosis, mononucleosis, something like that. A malarial parasite, though the malaria incidence has significantly gone down, dengue has superseded malaria, but yes, malarial parasite, that's what we normally do actually. And a urine analysis, but depending on your host, like an elderly who comes up more often with urine infection. So based on your clinical history and symptoms, we can decide what investigation has to be added subsequently. And if we follow this algorithm, chances of getting the outcome will be really higher. If we have a look at all these articles, this infection is significant cause of fever, particularly the prolonged fever, and then comes neoplasm, collagen vascular disease, miscellaneous, and undiagnosed fever definitely when it comes to prolonged fever. Because we are in tropical country, we are in India, so majority of our problems are infectious disease, and it is the 3rd largest killer in the world actually. Is it true for all age group? No. For younger people and elderly people, the differentials will be different. So if I have someone who is elderly, for me, malignancy, multisystem disease, something like temporal arteritis, endocarditis will be high on the risk as compared to someone who is younger. If I have a young female, the chances of having connective tissue disorder will be higher as compared to someone who is elderly. So all these things changes with the age. It changes with the risk factor. Like if I have a diabetic, the risk of complicated UTI something might be higher as compared to a non-diabetic person. So all these things have to be kept in mind. This changes completely in pediatric population. In pediatric population, though majority of it is infection, connective tissue is low, and malignancy and all other risk factors or all other diagnoses are low on the card as compared to infection. So majority of it is infection, and significant chunk of it is viral infection. So definitely we can sit tight and observe majority of it. When it comes to, so this was a paper from CMC Vellore where it's a good infectious disease team, and whether they have done hard work of getting diagnosis for prolonged fever. And then they could get melioidosis, endocarditis, fungal endocarditis, leishmania, and all unusual stuff, which we don't see in our day-to-day practice. But all these things are possible, and we have to keep that in mind. And in non-infectious, yes, SLE, vasculitis are really important, and we have to keep that in mind. If we have an elderly, neoplasm has to be there. So there is no excuse to good clinical history and thorough examination. Head examination should include from head to toe. So picking up your pallor, jaundice, lymph node, what is the type of node, whether it is necrotic node, whether it is tender. Skin examination can give clues like presence of rash. If it is a fever with rash, it might be a scrub typhus, spotted fever, or it might be with the summer coming up, we might have measles, varicella, and all these infections. Oral cavity examination gives us clue whether there are ulcers, whether there is candidiasis. Presence of candidiasis gives clue for uncontrolled diabetes, immunosuppressed state, or connective tissue disorder. And ulcers, again, connective tissue disorder, or viral fever, something like that. ENT examination was really crucial when we had mucor outbreak. It was really a tough time, and we never had seen so many mucors in our life. But yes, now also post-COVID, particularly post-Omicron, there are so many patients who are coming up with recurrent fever, and it's turning out to be recurrent sinusitis. So your thorough ENT examination, just doing sinus tenderness, doing a good oral examination will help you in getting the diagnosis and narrowing down our investigation and antibiotic. A joint examination can give us clue regarding polyarthralgia, polyarthritis, presence of clubbing, and organ involvement like liver splenomegaly. Doing a good auscultation definitely helps. When it comes to investigation, the basic investigation definitely gives us clue, like I said, whether there is leukopenia, which will support a viral fever, whether there is leukocytosis, which will be more of a bacterial infection, whether there is lymphocytosis, which will be again lymphocytosis and mononucleosis, that will again support a viral infection. So these are simple tests which will give us a diagnosis, or which will at least give us a clue to exactly how our workup should go up. And majority of the time, yes, we do get diagnosis with the basic tests. So if I have a patient with fever in my OPD, my basic test are CBC, CRP, and if I feel liver involvement is there, LFT, and then X-ray and ultrasound. So that gives me basic idea, and after that, with the clinical judgment, we can proceed exactly what should be done. So in nutshell, basically undifferentiated fever, if we have someone day 1 and day 2, sit tight, observe, antibiotic, we can wait. Day 3, yes, do workup based on the clinical syndrome. And day 5, we can add appropriate cultures if fever is persistent based on the clinical syndrome, what the patient has. Moving on to next case, 34-year male, presented with fever, nausea, vomiting, and diarrhea for 7 days, and had weight loss of 3 kg in 2 months, which is significant. So he had similar febrile illness twice in last 2 months and lasted for 5 to 7 days, subsided with antibiotics. So this is something which is responding to antibiotic, or whether it is just responding on its own and antibiotic is just been getting unnecessary credit. We really don't know. Let's see the reports. So patient was started on ciprofloxacin, which is the workhorse antibiotic, and all of us love ciprofloxacin, but then we should be aware about the drawbacks of using fluoroquinolones like ciproflox, oflox, because they have a lot of collateral damage. And once we give a course of ciprofloxacin, the risk of increasing MDR-TB is higher. Risk of increasing the resistant gram-negative is higher. So we have to be cautious while prescribing this antibiotic. On examination, this patient's spleen was just palpable, and these were the counts. So count was nearly normal with more of a normal differential. Platelet was normal, malaria, chikungunya, dengue, lepto, everything was negative. In prior hospitalization also, or prior episodes also, all these were negative, but then the fever episodes were recurrent. So exactly what was happening and what could have been the diagnosis. And yes, the Vidal was negative, which we do advise. So what is your diagnosis now? Whether it is malaria, typhoid, leptospirosis, dengue, TB, or it can be anything. Anyone wants to say anything? TB, typhoid, yes. So, yes. So if we feel this can be typhoid, what is your favorite test for typhoid? What do we advise in our OP practice? So options are Vidal, blood culture, clinical typhoid, because we feel typhoid investigations anyhow will be negative and we just give antibiotic, patient will settle down. We have wonderful card test available nowadays. And the other thing is just give antibiotic and let the patient go back. So Vidal, which we keep doing often, basically we should know exactly how it goes. So this is based on serological response to the antigens which the salmonella has, O and H antigen. Unfortunately, these are shared by other Enterobacteriaceae, and some patients don't mount an immune response and they might not have a positive taste. Many other diseases can give rise to false positive Vidal, and prior antibiotic exposure can affect the titer. So all these things we have to keep in mind. So sensitivity goes to less than 50%. If you ask me, in my practice, ever since I have joined infectious disease, I have stopped ordering a Vidal test, and we don't do a Vidal test because there are lots of false positives associated with Vidal, false positive and false negative. So we really cannot base our diagnosis of typhoid based on Vidal. Do we have any other test available? So as I said, yes, we do have card test available. So single Vidal, even the guidelines says single Vidal doesn't have a diagnostic significance. We can do a subsequent test to do titer assessment, whether it is increasing titer or not. But then, yes, we have to keep in mind before interpreting it that there will be a lot of false positive and false negative. So interpretation is really difficult, and particularly in a country like India where it is endemic, it becomes difficult to interpret all these tests which are based on the serology. The same problem comes with Typhidot. This is what we have is ELISA kits which detects IgM and IgG. IgM can come positive early and IgG takes time. So that is one thing we have to keep in mind for our serological test. Because when we do serological test, sometimes we order the test on day 4 of fever, and day 4 of fever our IgM might not be positive. So we might get a test negative. So that is one thing we have to keep in mind while ordering all serology tests, that even if it is negative in early infection, it might be that the patient has not mounted the response and that's why it is negative. So it doesn't rule out your infection. So there are papers wherein they say sensitivity is really good, but specificity is low. And basically, it still lacks the sensitivity and specificity because, as I said, we are in a country which is really endemic. And there might be cross-reactive natural titers or antigen in the society. So that's why interpreting antibody response in typhoid is not definitive or it's not diagnostic. Even WHO says the same. So the diagnostic is basically blood culture. Problems with blood cultures are we feel it's costly, and advising blood culture on a OPD basis becomes difficult because it's really a costly affair sometimes. And the other thing what we have doubt is whether blood culture will come positive or not. The sensitivity is around 50% and drops after we take antibiotic. How do we send blood culture? That is important, and that will improve the yield. So this was a paper from Camilla Rodriguez and Soman sir, wherein they have compared the blood culture positivity, and it was 50% despite being on antibiotic. So even if we know the patient is on antibiotic, it's worth sending cultures, because I have had patients who were diagnosed salmonella, but then fever was not responding, and from one antibiotic to other to third to even to colistin. So this is a scenario wherein sometimes it happens because fever doesn't respond. So if we are sure with the diagnosis, we can wait for fever to settle down, because it takes time for typhoid fever to settle down. The effervescence sometimes might be 7 to 8 days also. So this is one important thing we have to keep in mind. And as I said, blood culture failure is not always antibiotic. Yes, one reason is presence of antibiotic, but the important reason is inadequate lab media and the volume. So what we do is we send blood culture in small bottles. So volume is really small. So chances of getting a blood culture positive are really low. Ideally, what should be done is it should be sent in the Bactec bottle, and the amount of volume should be at least 40 ml. So which is like 4 bottles of blood culture we have to send. For pediatric population, yes, definitely, we cannot withdraw that much volume. So it goes down to 5 ml for a pediatric population. And neonates, yes, whatever amount we can withdraw, up to 0.5 also, it's okay. Previously, we used to say, yes, we have to hold the blood culture for 21 days, but with the newer bacteric system, wherein there are antibiotic-coated beds and all, we don't have to hold the blood culture for so long. Even for brucella, the blood cultures comes positive early. Now, if we diagnose typhoid, what should be given? So as I said, ciproflox is something which we really like and we advise. So this was my paper published in 2013 actually, and that time the cipro sensitivity for salmonella was roughly 54%. So 60% or nearly 50% chance if you are writing a ciproflox for typhoid will be wrong. The similar paper from IGMR data, this is multicentric data, and if we see, what we see in typhoid is half of it is typhi and almost 50% is paratyphi. Sensitivity to cotrimazole is really 100%. Ciprofloxacin is negligible for both of them. Azithromycin is really good, but then azithromycin, there are debatable sensitivity issues. Cefixime is good, but then the dose of cefixime what we are using has to be kept in mind because it's an intracellular organism. And as we know, prevention is definitely better than cure. So a vaccine is available, conjugate vaccine, which we can take every 3 years. And we can offer it to our kids also. So basically, for typhoid, the diagnosis is often missed. The good diagnostic algorithm and culture are really cornerstone, and we have to keep in mind that there is increasing fluoroquinolone resistance. Moving on to next case, this case I had seen when I entered Nagpur actually, and I did my fellowship from Chennai, wherein we used to see a lot of scrub patients. So this gentleman presented to us with left hypochondriac pain. He had this splenic infarct. The fever was persistent, was completely worked up for this splenic infarct. We thought it's connective tissue. Malignancy and other differentials were kept in mind, and they were contemplating a biopsy. Because of the clinical profile, the lab picture, I thought this might be scrub typhus. Had asked them for doxycycline. The diagnostic was not available. ELISA was not available here that time, so we had to outsource it to Mumbai. The day we started doxy, fever settled in 48 hours. So we could save a biopsy for him. And this is the beauty of doxycycline in scrub typhus. It really works magic for scrub typhus. So when should we suspect scrub or rickettsial fever in any patient? Any disease which looks like leptospirosis, which might be a hepatorenal syndrome. So patient might have hepatitis, patient might have renal involvement, a fever with rash. Sometimes there is leukocytosis, platelets goes down. There is liver involvement. Sometimes it just SGOT, SGPT elevation. Sometimes there is cholestatic hepatitis. Presence of HR, a skin lesion, is really diagnostic of scrub typhus. They sometimes present like acute meningitis, so altered sensorium. They sometimes come with renal failure, acute abdomen. I have seen patients who got admitted to surgery department with acute abdomen and subsequently got transferred because it was not acute abdomen, it was just scrub typhus, and sometimes present with sepsis multi-organ syndrome. So basically what we see aptly is FUO is deficiency of doxycycline, because we have enough number of scrub and it was misdiagnosed initially. Now with the awareness, yes, we are diagnosing scrub typhus and we are seeing a lot of patients with scrub typhus. It differs, the epidemiology differs. There are few parts of India wherein spotted fever is more common as compared to scrub typhus, and there are few wherein scrub typhus is more common as compared to spotted fever. This Isha will not be seen in spotted fever, but in scrub typhus, yes, we can see the Isha. Basically, there is jaundice signs. So all these areas which are hidden and wherein we have a tight clothes, we can get this Isha because the bug gets caught here and they bite and we get the Isha, and after that subsequently the scrub typhus. As far as diagnosis is concerned, Welfelix is very non-specific test and sensitivity is really low. Only when we have a dilemma whether it is scrub or spotted fever, we do advise Welfelix, because in spotted fever our scrub ELISA might be negative. Scrub ELISA is really sensitive and specific also. But as I said, we have to keep in mind that early disease, the serologies might be negative. So if we are getting a negative serology and if we still suspect it's scrub, we should continue with our doxycycline and wait for response. So in our study, majority of the patient responded in 48 to 72 hours after doxycycline, and very few, hardly 2% responded in day 4. So if your patient is not responding in 2 to 3 days of doxycycline, it's unlikely a scrub typhus, because doxy and azithromycin resistance is not seen in India. Western countries, yes, they do have resistant scrub. We don't have as of now. The MICs will be really increasing, but as of now, it's not reported. So doxy and azithromycin do work for scrub typhus. Moving on to next case, 45-year male presented with fever. He's a construction worker, had malaise, headache, lethargy. Examination is completely normal and labs are completely normal. So basically the possibilities here can be anything. And the construction, since he is a construction worker, related to that mosquito bite and all that, possibility of malaria is higher. So when we talk of malaria, what we do is antigen testing. The problems with antigen testing is the kits we use are related to HRP2 and LDH. The HRP2 kit, one part to highlight is basically the circulating antigen can stay positive up to almost 28 days in 30% of the patient. So when we say it's a recurrent malaria, it's a chronic malaria, we have to keep that in mind that yes, your test is going to stay positive, and it doesn't mean patient gets repeated infection unless and until it's clinically proven, or clinically and lab wise we do a peripheral smear and prove it. Unless and until it's proven, we cannot call it recurrent malaria just based on the antigen test, because it will stay positive for pretty long time. Yes, some strains will not have this HRP2 antigen, and that's why we might miss it. There will be cross reactivity, so we might get false positive, and the sensitivity varies from geography. So interpreting your HRP kit, we should be sure exactly what kit it is and how we are interpreting. In today's era, the guideline clearly says there is no role of empirical therapy for antimalarial, because we have wonderful diagnostic kits available. So all these RDTs, only in the areas where these diagnostic kits are not available, the guideline says, yes, you can give empirical antimalarial. Otherwise, yes, we should use these kits and give antimalarial. One thing we have to keep in mind is combination therapy is really important, because the artemisinin component, what we give, doesn't kill all the gametocite. And that's why we have to give the combination therapy like doxycycline, something which has prolonged half-life. This half-life is just 3 to 5 cycles. So we have to give something which has prolonged half-life and which will take care of the residual part of it that will prevent the recurrence. And the other important part is we have to do a weight-based dosing. Sometimes we do miss it, and in obese patients, we do get recurrence because of improper dosing. So when it comes to tropical fever, what we have to keep in mind is, yes, for all this tropical fever, there is a lot of overlap. So sometimes it becomes difficult, and doing a lab test is only rescue for us. Timing of diagnostic serology is really important in dengue fever. Not only in dengue, all the serologies, what we do, be it typhoid or scrub, timing is really important. We have to interpret our immunochromatographic test carefully. Never use artemisinin as a monotherapy. Epidemiology is really important. It's rickettsial disease. It might be spotted fever. It might be scrub. And we might get confused with other differentials. And doxy really works for rickettsial fever now also. Moving on from tropical fever to the next syndrome, what we have commonly seen for last 2 years, yes, fever, cough. All of us are really bored with this syndrome, but yes, there is no excuse from it, because apart from COVID, there are multiple other viruses which will keep doing this and which were doing this for so many years. So a 35-year male who is a non-smoker, presents with 5-day history of cough and malaise. Cough was initially dry, but now it's productive of thick yellow sputum. We always have a habit of asking what is the color of sputum, because we feel, yes, that will give us some clue exactly what organism, what bug it is, whether it is infective or not. Whether it's really true or not, I'll come to that in next few slides. So lung was really clear. His temperature was near normal when he came to OP. His oxygen saturation was normal. Chest X-ray was clear. So what is the best treatment option? Whether we should give amoxicillin, azithromycin, or oral cephalosporin, a levoflox, NSAID, or NSAID and salbutamol. So what we commonly choose is basically we just write some antibiotic, which might be any of this. So think about green discharge, as I said, green discharge or discolored discharge. It's not always infective. What happens is it's basically caused by myeloperoxidase. It's an enzyme found within white blood cell. So it will be present in any infection, be it bacterial or viral, as leukocyte aggregate to mucous membrane. And it doesn't predict whether it is bacterial infection, and it doesn't predict your response to antibiotic also. So change of color of your discharge has nothing to do with your infection profile, or whether it is bacterial or viral. So like we know, acute bronchitis is mainly viral. It might be influenza, RSV, parainfluenza, it might be rhinovirus, coronavirus, adenovirus, any of these virus. And there are a lot of causes like bacterial mycoplasma, chlamydia, legionella, pertussis. All these atypical infections are also possible. So when we have a look at the natural history of fever, basically in respiratory infections, fever settle down, but then the respiratory symptoms too, they persist for significant amount based on the involvement of whether there is significant bronchitis, bronchiolitis, all. So generally fever settles down on an average 3 to 4 days for majority of the viral infections. Yes, it doesn't happen in rare scenario, like if the patient has mononucleosis, in that case, patient doesn't need antibiotic, but then fever will continue. Sometimes respiratory symptoms are persistent or respiratory symptom disappear. But that is scenario in mononucleosis. Commonly, fever settles down. So basically, antibiotics work in selected scenario. In bronchitis, like I said, it's mainly viral, so we have to select our antibiotic cautiously. There are multiple randomized trials where they have compared the antibiotic effect on duration of cough, sputum, chest discomfort, return to work, and there was no significant difference in those who had received antibiotic and those who didn't receive antibiotic. So it's always better not to start it unless and until we are sure whether it is effective or not. Sometimes what happens is we feel, or the patient feels, is if I don't take it, it is not going to recover and I'm going to get secondary infection. But it's not everyone who gets secondary infections. So we can save these antibiotics, and those who have secondary infections, only those patients we can prescribe antibiotics. So they benefit very small chunk of patients, not everyone. So from this BMG trial, 53% got antibiotic for mean of 7 days. So that is significant chunk, and only 0.1% difference in symptom score after 7 days. So not significant difference in those who had received and who didn't receive antibiotic. Similar trial for amoxicillin, they didn't find significant benefit, hardly slight benefit, and some harm, because we know there's a lot of GI side effects associated with the antibiotic. So yes, we have to choose our antibiotic wisely while prescribing in those who have viral infections. Even in COVID, there are multiple papers which says there is no role of doxycycline or there is no role of any other antibiotic what we were prescribing, be it ivermectin, doxycycline, or any antibiotic, azithromycin. Any of these doesn't have any role. So even book says the same, be it Mandel's, Sanford Guide. They say what we need is salbutamol inhaler, and NSAID is shown to be effective in reducing the symptoms. There's no evidence that antibiotic helps in any way. Similar scenario, COPD patient who present, a chronic smoker presented with dyspnea, sneezing, and increasing cough, again a yellow sputum. But now we know, yes, it is not infection because it's yellow sputum. It might be something else also. So exam shows rhonchi, and his X-ray showed hyperinflated lung because it was COPD and emphysema. So the best antibiotic option is Amox, ampicillin, sulbactam, azithromycin. I have to give oral cephalosporin, or I should not give anything because I know it's this viral infection. So again, COPD exacerbation is more of it is viral bronchitis. Bacteria, they do colonize respiratory tract in almost 80% of them, and it's present even during periods of clinical stability also. But then acquisition of new strain of pneumococcus H flu have shown to result in clinical exacerbation. So basically, the clinical exacerbations are mainly because of flu, pneumococcus, and H influenza. So antibiotic basically will work only in those with severe COVID, severe COPD, and those who had respiratory failure or increasing oxygen requirement. Otherwise, just COPD exacerbation, your symptomatic treatment is good enough. And even if we are deciding to give antibiotic, it should be targeted to strep pneumoniae, H influenzae, and mycoplasma, which will be ampicillin is good enough. Doxycycline will cover H influenzae and moraxella and Legionella, the atypical ones. So we have to keep that in mind. This is a common scenario, what we see in our practice. Young female, there's coming with dysuria, increased frequency, hematuria for 3 days, there's no fever, vomiting, and urine shows pustule. Now, there is always a dilemma whether we should give antibiotic upfront or we should not give, just right symptomatic, alkalizer, and increase water intake, whether it's going to help or not. So basically, there is no fever, so it is cystitis, it is lower urinary tract infection and not upper urinary tract infection. Generally, upper urinary tract infections are associated with fever, and lower urinary tract infection don't have fever, barring prostatitis and prostatic abscess, all those infections. So basically, this is simple case of cystitis. So what guideline says is, as I said, there is always a confusion whether we should get a urine culture done, whether we should give antibiotic. Now, while giving antibiotic, whether it should be cotrimazole, ciprofloxacin, nitrofurantoin, or cefixime, all of these are easily available. And yes, we do like all of this. So what should be the option in all these patients? So before choosing the option, what we should know is, when we do a urine culture, this is ICMR data, recent data. So 75% of it is Enterobacteriaceae, matlab it is E. coli and Klebsiella. Then we have a bit of it is Pseudomonas and non-fermenter gram-negative. It can be Staphylococcus, Enterococcus. Again, on very specific host, immunocompromised host, or those who are CLD and all this patient, we get it. Normal patients or those who have no comorbidities, common is what we see is E. coli and Klebsiella. So sensitivity wise, if we compare, here we can see it's mainly this. And sensitivity wise, if we see, ciprofloxacin sensitivity again is significantly lower for these also. Cotrimazole sensitivity is roughly 50%. Nitrofurantoin varies for 83% for E. coli and Klebsiella, it is 33%. And cefazolin is resistant. That means these are ESBL, and majority of our cephalosporin will not work because India, the ESBL rate is almost 70%. So if we are writing cephalosporin or ciprofloxacin or any fluoroquinolone, the only thing we have to keep in mind is the risk of resistance is really higher. And if we are giving and if it is working, the only reason why it is working is urine concentration for all these antibiotic is really higher. So we have to be sure whether we really want to treat it or not. And if you want to treat it, ideally we should choose the antibiotic based on the culture. The guideline says for cystitis, we don't need culture as such. But yes, when it is recurrent cystitis, you should not write blind antibiotic, because we are in a scenario where our cultures or where our antibiotics, bugs, bacteria, they don't respond to normal antibiotic course. So we should have a good culture from a proper lab who gives us a good colony count and who gives us an automated culture report, because sometimes interpreting culture report is also a trick, and you need to know how to interpret it, because there are very erratic reports which are there. So antibiotic wise, yes, nitrofurantoin for 5 days. Again, it depends on the local resistance and your local antibiogram. We have to decide what is to be given. All these have to be chosen based on the resistance profile. So if resistance rate is really higher, which normally is, we should avoid this antibiotic. Cultures are crucial, and while sending culture, few tips for sending culture is urine culture should be sent promptly within 2 hours after collection, or if we are not able to send it within 2 hours after collection, it should be preserved in the refrigerator. What happens practically is people do collect it. There was one transplant patient of mine who had urine culture staph. So normally Staphylococcus is not there in the urine. If we get Staphylococcus, the reason is basically the patient has staph in the blood. So if we feel transplant patient has staph in the blood, it was a difficult scenario. Then I asked him the details, and I came to know that this fellow had very small quantity of urine, and that's why he collected drops of urine overnight, and then he sent it for culture. So it was a contamination collection error, or because the sample was lying throughout night in the room temperature, so that it was overgrown by other bugs rather than the urine bug. So all these things we have to keep in mind while interpreting urine culture also, and we have to give all this instruction to our patient that they have to collect midstream urine after good cleaning of the area. Otherwise, we'll get fecal flora or this clean flora, and it will be difficult to interpret and difficult to treat also. A 79-year female, this is very common scenario, and people are really troubled to see their culture report. Even if we are comfortable, they are not comfortable with the report, and they do ask, yes, my culture is not becoming negative, I need antibiotic. So a 79-year diabetic female has urine analysis shows a bit of a pyuria, which was performed as a part of her lab screening. She was absolutely asymptomatic, and the urine culture grows E. coli. Now, what should be done? Yes, I have to repeat the urine culture and treat if culture is positive, or just give off the antibiotic, or we don't need any treatment at all. So this is common scenario we face in our day-to-day practice, and very often. And like us, even our patients are impatient and they want some answer for it. So if culture is positive, it has to be treated. It has to be treated. And the commonest what we have is fluoroquinolone. That's what it is, dictum, or that's what we feel. So there is something called as asymptomatic bacteriuria, and there are definitions for it. It's different for female and male, because male, even single sample is enough, and for female to label it, we need 2 consecutive sample, preferably within 2 weeks, to confirm that it is asymptomatic bacteriuria. And the colony count should be more than 10⁵. It's pretty common, and almost 15 to 20% of the elderly population have it. Even young diabetic population can have asymptomatic bacteriuria. So there are multiple papers or studies wherein they have compared treating it and non-treating it. So the treatment resulted only in temporary eradication with subsequent recolonization. So there was no benefit in giving antibiotic, because again it came back. So it was just transient relief, and there was no permanent cure for it. The side effect of antibiotic were really higher, and in some incidence of symptomatic UTI was same in both the groups. So it didn't prevent even the symptomatic UTI in subsequent time. The other practical problem in treating all these is, as I said, the resistance scenario is really increasing. So what options we have is majority of the time injectable. And if someone is asymptomatic, why do I need to give injectable to the patient? So this is one thing we have to convince ourselves to convince our patient, then it becomes easy to convince them. So the only indication for treatment is pregnancy. Even in pregnancy, there are trials. There was a study in Netherlands wherein they have compared giving antibiotic for a urine culture positive in pregnant female versus not giving, because we feel it might precipitate early labor. So they didn't find any risk with that. And the other practical problem what we face is giving a resistant, handling a resistant bug. Like I might have a culture of E. coli, which is sensitive only to colistin. Will I give colistin to a pregnant lady just because she has a symptomatic bacteria? I will not. So these are the practical problems we face. And yes, we should be aware about the guidelines while handling these. Recurrent UTI, though, yes, there is chunk of patient who has asymptomatic bacteria or just culture positive, but then yes, there is significant chunk of our patients, particularly female and menopausal female and young females, who have recurrent urine infections. So what is important in all these patients is we should ask the history, get the whether it is postcoital, whether there are episodic chill, whether the patient has prostatic symptom or not, partner skin, because quite a few number of time it's not just cystitis or something, it might be urethritis and vaginitis also, which is been mislabeled or confused as cystitis. There is always no excuse for examination, so examination do help. It might be phimosis, balanoprosthesis, or vaginitis. There might be obstructive uropathy, which is not treated properly, so imaging or a proper workup like cystoscopy might help in all these patients, rather than just putting the patient on chronic suppressive prophylaxis. And since we don't have much option left, the focus should be on the reduction of risk factor, treatment for etiological management, and non-antibiotic prophylactic measures rather than on the antibiotic prophylactic measures, because antibiotic prophylactic measures are really limited and we have very few options like cotrimazole, nitrofurantoin, fosfomycin, cephalosporins if they are sensitive, but very few occasions we do get this scenario wherein it is sensitive. If we advise the prophylaxis, generally the duration is 3 to 6 months. So basically for UTI, what we have to keep in mind is asymptomatic bacteria is debatable. We have to know whether to treat it or not is debatable, and majority of the time you should err on the side of not treating it, because there are very few proven indications. We should know our antibiotic wells, we should know our bugs well, and for recurrent UTI, what is important is doing non-antibiotic intervention, doing the imaging, rather than focusing more on the antibiotic prophylaxis. That should be the last resort. If you are done with everything and you're not getting the patient sorted out, yes, we can think of antibiotic prophylaxis as well. Moving on to the last syndrome, skin and soft tissue, which we see often. So this gentleman had just redness of skin, presented with knee pain for a day duration, and he landed up in ICU with transient vasopressors, fall in BP and all. Normally we see this scenario if this patient had normal pressors, normal blood pressure, and he was stable, and if he had come to OPD, what would have said is this is just cellulitis and treat it like simple cellulitis. So if it is cellulitis, what is the organism which is associated? Mainly it is beta hemolytic streptococcus and staphylococcus. Staphylococcus can be MSSA and MRSA. So antibiotic, what will work is ampicillin, sulbactam, cephalexin, proxycillin, and clindamycin. What is the common mistake we do is we give ciprofloxacin, the higher generation fluoroquinolone, gram-positive cover is poor. MRSA cover is required only if the MRSA incidence is higher, or if the clinical syndrome is suggestive of toxic shock or similar presentation. In non-purulent cellulitis, MRSA coverage is not required. So this gentleman was basically a case of necrotizing fasciitis, and it was not simple cellulitis. So having a high degree of suspicion is really important when we deal with skin and soft tissue infection, particularly in high-risk adult. Even in normal patient, we can have complication with cellulitis, basically related to the toxin production, what these staphylococcal and streptococcus have. The commonly seen skin infections are basically boils, and I guess I have a slide on that. So a non-diabetic farmer presents with fever, redness, and he has all this recurrent episode of cellulitis. So recurrent non-necrotizing skin and soft tissue infections like recurrent cellulitis and recurrent boils are pretty common, and almost 20 to 50% of the patient, they do give history of one prior episode of cellulitis. 14% of them had the episode within 1 year and 45% within the 3 years. So generally tend to occur in the same area. And as I said, it's mainly by streptococcus. But then there are predisposing factors for it. So if we look for these predisposing factors, it definitely helps us in treating it, because then if we do the correction for this, like lower extremity edema, sometimes the skin is really dry and they scratch and they get infection. There's obesity, there is eczema, there are gaps, or there is tinea in between the toes. So, and there might be venous insufficiency. So, and sometimes it is uncontrolled diabetes per se, which precipitates all. So if we take care of all these simple things, we can definitely provide this recurrent skin and soft tissue infection. Someone who has recurrent boils, what is advisable is staphylococcal decolonization, which includes mupirocin ointment and chlorhexidine body wash. So I guess in nutshell, I have covered majority of the syndromes what we see in our OP practice. There is a lot more into it, but I don't think it's practically possible to cover everything here. So it started with Nipah, then we had other bugs, and then we had COVID. But is it going to end it here? What is it? Basically, like I said, China had just declared closures. So we might have further for the viruses, outbreaks, pandemics, endemic. Hopefully there should not be a similar pandemic in any near future. No one wants to face any similar pandemic, but yes, we should be prepared for all these things, because it's an era of new bugs coming up, and we do have re-emerging infections. So in short, what I'll say is not all the fevers are infections. Not all infections and cultures need antibiotic. We have to choose our antibiotic well. There's no alternative for a good history and examination. And yes, we should know how to interpret our labs, because it's really crucial. Otherwise, we'll keep over-treating all these labs. So thanks for patient listening, and I'll be happy to take the questions.
Heartily congratulations. Ashwini ma'am, you have completed all the common infection scenario in a very simplified way for all the members present here. Right from the topical fever to COPD, even involvement of UTI, complicated UTI, and the skin and soft tissue infections. You have covered all the infections, common infections very well, and the great take-home message also you have given rightly. I will only add one simple thing. As all NIMA members, this is one of the greatest community serving India to be as a front worker. Whenever there is patient with infection, he is coming to you and you are the first person to deal with the patient. So today's scenario, today's lecture, today's presentation of Dr. Ashwini on this common infection will be very much helpful to you to choose, not to choose, and which antibiotic should be used. So if any questions are there, it will be very much helpful for you people. So once again, congratulations, Dr. Ashwini ma'am.
Thank you.
The NIMA members, you are in all the women's, as we are celebrating this Gnan Yajna on, and this webinar is devoted as on the Women's Day celebration, and you have chosen one of the versatile speaker and versatile infectious disease specialist from the Nagpur, who had covered this so much difficult and complicated topic up to each and everybody's level. So once again, I thanks all the NIMA members who have attended this today's seminar, and congratulates all the NIMA members and all the women members of this women wing for this today's webinar. If few questions are there, we will take it. Our speaker is ready for the questions.
Hello. Sir, कोणाचे questions असतील ते मी chat box मध्ये टाकायचे. Meanwhile, मॅडम काही एक दोन questions आले ते मी सांगते तुम्हाला. The question is, you mentioned in acute bronchitis, salbutamol and NSAID works. Which NSAID you are referring to? Referring to which NSAID is the question.
A simple paracetamol, high dose paracetamol will give you a good anti-inflammatory activity also and antipyretic activity also. And then it's mainly your bronchodilation which is important. So that will give you a benefit.
Next question is, what treatment when PID is present due to recurrent UTI?
PID is present due to recurrent UTI. Recurrent UTI. So recurrent UTI, PID might be misinterpreted as a recurrent UTI, but then PID and UTI is a different syndrome. So basically UTI will be your blood, cystitis, pyelonephritis, prostatitis, all those things. So what is this question? What will be the treatment when PID is present due to recurrent UTI? So basically these are two different entities, and if it is PID, we will have to work up exactly what is the etiology and what is the reason patient is not responding, whether it is improper treatment, improper duration of treatment, the partner is not done. So all these things, it should not be mixed.
Next question is, what is the role of alkalizer in cystitis?
They do give symptomatic relief, but then it's cystitis, it's bacterial infection. So a short course of antibiotic is required. So that's why differentiating infective etiology from non-infective is really important. So sometimes the ultrasound do help us in knowing whether it is cystitis or not. So बायोरिया किती आहे, ultrasound वर cystitis आहे की नाही, या गोष्टी जर आपण बघितल्या, so I guess that gives us information whether we are dealing with the infective etiology or it's just a symptomatic thing which is going on and we are unnecessarily giving antibiotic. That happens actually. So that has to be ruled out with a good imaging, and urologist might help sometimes.
Question is there. What is the cause of non-healing wounds or gangrenous wounds? Are they infectious always?
Non-healing wound, the commonest what we see is diabetic patient because they have peripheral vascular disease, they have neuropathy and uncontrolled sugars. So these are the ones wherein we see commonly non-healing wounds. And treating having a good glycemic control helps. But yes, there are few like actinomycosis, nocardia, fungal infections, filarial patients wherein yes, they do get those who have lymphatic obstructions, they do get recurrent infections, or someone who has peripheral vascular disease, they will have recurrent or non-healing wounds. So taking care of the predisposing factor is important rather than just doing the surgical or antibiotic part.
One more question was asked. I think this question is related to COVID vaccination. Is it booster dose necessary or useful?
Booster dose, particularly those who are immunocompromised elderly, wherein we know yes, vaccine take is going to be low, and we know after 6 months it's waning immunity. So in those patients, yes, it is indicated and it is required. And it has definitely proven less hospitalization and ICU admissions in all these patients.
Thank you, ma'am, for such a knowledgeable lecture. Dr. Survase sir, if you want to add something more to these things, then
Yes. One more
I
thing.
will request you to add few points.
Right. Nowadays, we are in the post-COVID scenario. We are seeing so many patients with chronic cough. And even in the month of January and February, we also simple COVID taken treatment at home. But in OPD patients, those fever who is not responding to the routine treatment, fever is there, fever may not be there, but weight loss and other symptoms, constitutional symptoms, so many patients of tuberculosis we are getting in our day-to-day scenario. In my today's OPD only, I have detected 2 MTB positive, which days back I have seen simple fever with 3 to 4 weeks duration, post-COVID, dry, X-ray chest is clear, even blood profile is okay. So this is my request to all the members, while screening the patients of fever, this post-COVID cough, which is not responding to the routine line of treatment, and if they have some constitutional symptoms, keep a high suspicion of tuberculosis also. And we all have a easily availability of gene expert test for the detection of tuberculosis, which is freely available. Don't use this facility for each and every suspected patients of chronic cough, which is not responding to the routine line of treatment.
Very true, sir. Completely agree. Yes, we have seen increasing number of TB very significantly in post-COVID. Might be pulmonary or extrapulmonary also. So
yes, right. And ma'am had completed each and every topic so elaborately. From my end, there is no need to add anything. So once again, I congratulate and I give a good. I thank you all the members of the NIMA. I have a great word of thanks to all the dignitaries of the NIMA, state, all the body members, and all the women wing members. This is really a great continuous activity of your this 74 years, 75, 50 years celebration. And it is a very great academia or Gyan Yajna is going on. Just keep it up to update your knowledge in your day-to-day practice. And we all as a medical community are there to help you all to be a real front work, what we can say, as whenever you are dealing in any patients, first patient come to a family physician. And in this family physician practice in India, maximum 95% patient will reach to you people. So early diagnosis. And whenever there is in our mind related to these common symptoms, syndromes, and scenarios, you can pick up these early infections or early emergency, and we can save, as in acute MI or acute stroke, we say as a golden hour, 1 hour or 3 hours, right? In stroke in 1 hour, and in AMI as a 3 hours. In the sepsis and septic shock syndrome also, this scenario is less than this 1 hour, 3 hours. So by getting this updated knowledge, you will be more equipped to clinically suspect, diagnose, and treat these cases of even fever, sepsis, and complicated sepsis. So thank you once again, all of you, and wish you all the best for this GAN Yajna forever. Thank you very much.
थँक्यू सर आपला एक्सपर्ट कमेंट्ससाठी. आता आपण या कार्यक्रमाच्या अंतिम टप्प्याकडे आलेलो आहोत आणि अंतिम टप्पा, जरी टप्पा अंतिम असला तरी अत्यंत महत्वाचा आहे, तो म्हणजे आभार प्रदर्शनाचा. तर या कार्यक्रमाचं आभार प्रदर्शन करण्यासाठी मी डॉक्टर पार्वती राणे, ट्रेजरर नीमा वुमन्स फोरम महाराष्ट्र राज्य यांना इथे बोलावते. डॉक्टर पार्वती राणे.
हेलो मैडम.
येस मॅम.
हेलो मैडम, आवाज आ रहा है?
हाँ आ रही.
हाँ, थैंक यू स्वाति काले मैडम, ग्रेट anchor for this webinar. Thank you very much. And now I really thanks to Dr. Ashwini Thade madam for a beautiful lecture for the demystifying myths in common about common infections. Madam is very smart with her specious treatment practice of infection and adult vaccination. But nowadays, infection is very common. It may be viral, it may be fungal, or it may be bacterial. But reality with these infections are very important, and myths are also important for diagnosis and treatment of that infections. And I thanks to Madam for her precious sparkle speech, and also she is a very sparkle doctor from Medical Society, and I say to her Happy Women's Day from all of us. And Madam now clear many myths and highlights her study for typhoid, scrub typhosis, malaria, tropical fever, COPD, cystitis, and recurrent urinary tract infections, cellulitis, and SSTI. And today she is giving her knowledge for us. Thank you very much, madam. And now I just say thanks to our lovely chairperson, today's our chief guest, Dr. Vaishali Padghan, madam, for her remarks to us, and thank you very much. Now I today say thanks to our chairperson, Dr. Narayan Sarvase sir, for her beautiful remarks, and also I thanks to our co-chairperson, Dr. Sheetal Roman Shinde madam, for her remarks to us and for beautiful biodata presentation. And now I just say thanks to all our central PST, NIMA Central PST, President Dr. Vinayak Tembulkar sir. I thanks to our NIMA Central Treasurer Dr. Ashutosh Kulkarni sir, and also thanks to Dr. NIMA Central Secretary Dr. Pandey sir. And I also thanks to our NIMA Central President Dr. Women's Forum President Dr. Sadhna Kulkarni madam, and I also thanks to our NIMA Central Vice President Dr. Vaishali Padghan madam, and now she is our chief guest for this program. I especially thanks madam, and I also thanks to our NIMA Central Women's Forum Secretary, Dr. Mrunmai Masotkar Madam, for her guidance and support. I also thanks to very much to Central PST. And I also thanks to Dr. Suha Javdar sir, our NIMA Maharashtra State President. And I also thanks to Dr. Anil Bajare sir, our Secretary, Maharashtra NIMA branch. And I also thanks to Dr. Bhushan Vani sir for her valuable economical support to us. And thanks to Bhushan Vani sir for a treasurer of NIMA Maharashtra. I thanks to our dynamic personality, President Dr. Swapna Jagdale Madam, for her cooperation. She is our NIMA Maharashtra State Women's Forum President and always guided us for valuable programs. And I also thanks to Dr. Rajeshri Shirpurkar Madam, our NIMA Maharashtra Women's Forum Secretary. She always guided and always do grateful work for us. I also thanks to NIMA Maharashtra Student Forum who always support and are always with us. I also thanks to all office bearers and all executive members of NIMA Society. NIMA PST always helps us to NIMA Women's Forum. This is great job for us and we are always ahead with each other. And now I also thanks to our all branch PST, main PST and also NIMA Women's Forum PST who always ahead with every work of humanity. And I also thanks to everyone. अगर मैं किसी का नाम लेना भूल गई हूँ तो सॉरी, समय की कमी के कारण मैं किसी का नाम नहीं ले पाई तो मैं इसके लिए चाहती हूँ और मैं बहुत ही आभार व्यक्त करती हूँ हमारी प्यारी सी डॉक्टर स्वाति काले मैम का जिन्होंने इस वेबिनार को बखूबी पूरे स्टार्टिंग से लेकर अभी तक के पूरा किया है। हमारी इस सुंदर सी मैडम का बहुत बहुत धन्यवाद और सभी यहाँ पर उपस्थित डेलीगेट्स को बहुत बहुत शुक्रिया। उन्होंने बहुत ही अच्छे से हमारे कार्यक्रम को सुना और अपने जो भी अपने डाउट्स थे उसको क्लियर किया। इसके लिए आप सभी का बहुत बहुत धन्यवाद। और मैं अब चाहूंगी कि हमारे मेन पीएसटी नीमा महाराष्ट्र स्टेट पीएसटी और नीमा महाराष्ट्र वुमेन्स पीएसटी से विदा लेना चाहूंगी इस कार्यक्रम की समाप्ति के लिए।
सर जाधव सर आहेत का?
मैडम मैं हमारी सुंदर गायिका के लिए बोलना भूल गई, सॉरी। अर्चना मैडम ने बहुत ही सुंदर तरीके से गायन धन्वंतरी श्रवण गाया है। वो हम कह सकते हैं कि हमारी नीमा की एक मैं उसे एक उपाधि देना चाहूंगी लता मंगेशकर की, क्योंकि वो इतना सुरीला गाती है जैसे लता मंगेशकर जी गाती थी। तो मैंने उन्हें बहुत रिक्वेस्ट की और उन्होंने तुरंत ही हाँ कर दी और बहुत ही कम समय में अपना गायन प्रस्तुत किया। इसके लिए मैं उनकी बहुत बहुत धन्यवाद कहती हूँ। मैडम पीएसटी दिख नहीं रही है।
हेलो
हेलो
पीएसटी पे के बोल। हाँ सर एंड करायचे सेशन।
धन्यवाद
चालेल
भावने सर डॉक्टर थँक्स टू टेक्निकल टीम ऑल्सो।
नीमा महाराष्ट्र राज्य शाखा आणि वुमेन्स फोरम नीमा महाराष्ट्र राज्य शाखा यांच्या पीएसटीच्या अनुमतीने आजचा कार्यक्रम इथेच संपला असं मी जाहीर करते। सर्व मान्यवरांना आणि जितकेही सगळ्यांनी लेक्चर अटेंड केलं त्या सर्वांना धन्यवाद। Thank you.
Thanks a lot, everyone. Thank you. Thanks again. Bye.
Thanks.